Hello, and welcome to the Guthy-Jackson Charitable Foundation Education Center and its NMOSD Grand Rounds. We welcome everyone in attendance and would remind attendees that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Grand Rounds series has specific overarching goals. First, to be a practical summary of the latest information on the topic of the presentation. Second, it's designed to emphasize key themes and clinical pearls. It's also meant to be inclusive of non-specialist audiences. And as you'll see toward the end of the presentation, it contains a pocket guide that is meant to highlight key points as a reference. Please note that there is eligibility for continuing medical education for those viewing this presentation. To do so, follow this process. Visit the GJCF Education Center using the QR code shown here. Select the session and register for that session. View it and fulfill the CME requirements. Then receive the CME certification online. My name is Dr. Michael Yeaman, and I'm an advisor of the Guthy-Jackson Charitable Foundation. And I am delighted today to introduce you to Dr. Scott Zamvil. Dr. Zamvil is professor of neurology and immunology at the University of California, San Francisco, and a world expert on the immunology of NMOSD. His topic is pathogenesis and immunologic targets of NMOSD. Scott, thank you so much for being here, and we really look forward to your presentation.
Michael, thank you for the invitation to join for the NMOSD Grand Rounds, and I'm happy to present on the pathogenesis and immunologic targets in neuromyelitis optica spectrum disorder, NMOSD. So what my objectives are, is that I will first speak about the pathogenesis and targets in NMOSD. I'll speak to the importance of T cells, B cells, and antibodies throughout. I will also speak to the importance of immune tolerance and how NMO is distinct from possibly other autoimmune diseases of the central nervous system. And what I will do is then discuss the different therapies that we have for NMO. Those are the approved therapies. And then what are the future therapies? Where are we going from here? So just as background, it took us a long time to define the disease neuromyelitis optica. It was first described in the 19th century by Devick's disease back in 1894. But it was 110 years later when we understood that this condition, which is characterized by optic neuritis, sometimes bilateral optic neuritis, and myelitis, is associated with an antibody called NMO-IgG, and I'll discuss that in greater detail. NMO itself is a rare disease. When we compare it to MS, it's about 2% or 1/50th as common as MS. It is characterized clinically by spinal cord involvement, myelitis, eye involvement, optic neuritis, and also another syndrome that occurs that is characterized by hiccups or nausea and vomiting, which has to do with the involvement in the area postrema around the fourth ventricle. NMO is often more severe than MS. Disability in NMO is associated with clinical attacks. It's a relapsing remitting disease, and the disability accumulates over time with each event but it is distinct. Unlike MS, there is no clear secondary progressive phase in NMO. NMO is induced, or I should say is associated, it's caused by antibodies to aquaporin 4. This is the NMO IgG discovered in 2004, and the target was identified a year later. AQP4 is expressed in the central nervous system on the astrocyte at the very end of the astrocyte end-foot processes, which attach or make up part of the blood-brain barrier. AQP4 is the target in a majority of patients with neuromyelitis optica, and we call that AQP4 seropositive, anti-AQP4 antibodies seropositive. But it doesn't cover everyone, so that there are patients that don't have the antibody. Interestingly, up to 25% of patients, up to a quarter of them, they may have other coexistent rheumatologic conditions like Sjogren syndrome, lupus, or systemic sclerosis. There is a gender bias, just like in other autoimmune diseases, we see a female to male predominance like lupus, which is even a little bit higher, 10-1, and NMO overall about 8-1, but for those that are seropositive, for those patients, it's 9-1. This shows on the MRI on the right side here, shows a longitudinally extensive demyelinating lesion right here on a T2 image. Often the T2 image is associated with enhancement on gadolinium injection here, and that's shown here. So this is a characteristic lesion that we would see that helps us differentiate with multiple sclerosis, where the lesions might be a little bit shorter and they might not be located in this particular location, but up in this area right here. NMOSD, the diagnostic criteria, is had a number of iterations, and this is the one we use currently, is the 2015 IPND, which is the International Panel of Neuromyelitis Optica Diagnosis. It's a team that has worked on the diagnostic criteria. It's very, well, I should say it's easy, maybe not very easy, but it is easier to diagnose when the patients have the antibody as shown here. This is AQP4 seropositive NMOSD. So if the patient has one clinical characteristic and the antibody, such as an optic neuritis or a myelitis or the area postrema syndrome, and they have the antibody, we can make the diagnosis. It becomes more complicated when the patients don't have the antibody or we don't know the status because it hasn't been tested. And in that case, we have more stringent criteria that require having more than one clinical criteria, 2 core criteria, and the imaging criteria is a little bit more select as well. In other words, or more strict in terms of what we need to see. There needs to be evidence of having more than one lesion or change over time. So that is the diagnosis and how we use that. What is the pathology of NMO? I mentioned already that it's NMO IgG and it targets AQP4, which is shown here. This cartoon here, this illustration shows you blood, the CNS parenchyma, and the CSF. The antibody is produced primarily outside the CNS, and the peripheral blood is where we detect it, so that it's 350 or 400 or 500 times higher than it is in the CSF. So it's an outside-in pathology. The antibody crosses into the central nervous system in association with infiltrates cells. And in NMO, it's monocytes, B cells, you have neutrophils and eosinophils. The predominant cell type really is the neutrophil, and second would be the eosinophil. The antibody binds to here, to aquaporin 4. It then activates complement, and that leads to tissue destruction. And that's shown over here. You have antibody deposition, you have complement, you have inflammation as well, you have a loss of astrocyte GFAP. GFAP is a marker for astrocytes, and that's lost as is shown here. You have demyelination, which we believe is secondary to the damage that occurs there as well. So it's interesting that we have the damage in NMO is in the central nervous system on the astrocyte there. However, aquaporin 4 is expressed in other tissues. Aquaporin 4, as I've mentioned, it's in the CNS, as shown here, but it's a family of water channels. And there are other ones that are expressed. In the brain, you have aquaporin 1 and aquaporin 4, but primarily 4. In the eye, you might have aquaporin 5, the same in the lacrimal gland. Aquaporin 4 is found in the kidney, it's found in the lungs, it's found in muscle, and it's found in the stomach as well. So many different tissues. But the antibody and the disease in general is restricted to the central nervous system on the astrocytes that express the aquaporin 4. So you ask the question, why? Why would it be selective for aquaporin 4 in the central nervous system? And that's because the aquaporin 4 there is expressed in a very unique manner. What happens is the aquaporin 4 forms tetramers there. There are different isoforms of aquaporin 4, but the one that's found in the central nervous system forms a tetramer. And that tetramer then forms a lattice formation. The antibody can then bind to that lattice formation in a very unique way because there's a geometric configuration here that the antibody binds in a way that's monovalent. So you see one arm bound, but the distance here is a specific distance that permits the complement, the very beginning of the complement system, to bind those antibodies and activate the complement system, leading to the astrocyte toxicity. You don't see the orthogonal array of particles. That's what the OAP stands for. You don't see that in other tissues that express aquaporin 4. It's different than in MOGAD, which we talk about as another disease that's been described even more recently, or recognized more recently. And that antigen is the MOG itself, myelin oligodendrocyte glycoprotein. MOG is expressed on the oligodendrocyte, as it denotes, and not on the astrocyte. And that's shown here. But we don't understand the mechanism of destruction of oligodendrocytes in MOGAD. For example, here, does it activate complement? Does the antibody bind monovalently? One arm is shown here. There's some data suggests that the antibody binds two different MOG particles, or MOG proteins, but you don't have a lattice formation. There's also evidence not only of complement-dependent cytotoxicity that you would have here with C1q. In vitro, we can show that, but we don't know in vivo. There is evidence of complement deposition in some, but not all patients. We also have evidence for antibody-dependent cell-mediated cytotoxicity, which involves the natural killer cell. And those cells can actually participate in damage in vitro, maybe in vivo. And lastly, we have antibody-dependent cell-mediated phagocytosis, where a myeloid cell, a macrophage, a microglia, a dendritic cell might phagocytize the oligodendrocyte. And that then leads to the damage in MOGAD. So it's a different target. The pathology is different. It's not neutrophils and eosinophils, but there are lymphocytes in those lesions, more akin to what we might see in an MS lesion. Now I'm going to move towards the immunology. There are different cell types that I've spoken to already, the T cell and the B cell. The three components are B cells, T cells, and the antibodies. They interact in a reciprocal manner. They have to speak to each other, and the T cell helps the B cell helps the T cell. The B cell expresses these molecules here called MHC molecules. They can present the antigen in NMO being AQP4 to the T cell. But then you need to have T cell help for the B cell to make the antibody. And the T cell speaks to the B cell and promotes its differentiation, its division, its ability to secrete antibody and to form more specific antibodies, higher affinity antibodies. So the T cell is central, even though it's behind or beneath the surface of the water, as the example of an iceberg here would be. The T cell is important, but you don't necessarily see it. T cells themselves have an important function, but their differentiation is we call them T cells. The T stands for thymus. I refer to it as the teacher, but it's really the thymus. And they have to be educated from elementary school through university by going through the thymus. And the thymus itself has three different functions really in the maturation of a T cell. It may begin in the bone marrow, right, as shown here. It may then transfer to the thymus, and it has to exit the thymus. The thymus itself has different portions, both the cortex and the medulla. And the interesting part is that there are three different possibilities. First, when a T cell from the bone marrow, pre-T cell, a progenitor T cell, enters the thymus, it may enter into the cortex, which is shown here, not necessarily the medulla. What happens is that it has to see an antigen in the thymus. The thymus is a special organ. It's a library. So instead of having just a single antigen, it is a library of many different books, or here in this case, antigens. And you select different antigens that are there, self-antigens. You don't want autoimmune disease, so you present those different antigens, foreign and self. You would like those cells that see foreign antigen to emigrate from the thymus and mature. What happens is if the T cell doesn't see an antigen at all, it has a low affinity, it dies, it gets killed, it undergoes apoptosis. Conversely, if it has affinity that is too high, and here is shown another cell type in the thymus that presents different antigens, if it's too high of an affinity, they die. It's only the cells that have an intermediate affinity that enter the thymus that can exit the thymus, and it's a very small proportion of 1 to 2%. Again, the thymus is a library of many antigens. All of our self-antigens are thought to be presented in the thymus, and we lead to self or deletion, self-tolerance in the thymus. Only those that recognize foreign antigens should leave the thymus. It doesn't happen that way. Some of the self-reactive cells do escape as well. So this is known as the thymus's central tolerance. What happens if they escape? Well, if they do enter the periphery, we have a safety net, many different layers in the safety net. We have another possibility is that the T cells escape and they can become regulated. We also know that in the periphery, they can be inactivated and still survive. So they don't proliferate, they don't act at all. And another one is just like in the thymus where you get deletion, peripheral deletion may occur as well. So there are different possibilities, and it's important because we have to have a safety net to prevent autoimmune disease. Unfortunately, when it's dysfunctional and there is escape, we can't easily correct it. And that's what we're trying to do in our therapies. Again, here is a slide that shows the cells that I mentioned here, the T cell. The T cell itself has to interact with an antigen-presenting cell. It could be a myeloid cell. It could be a B cell. They have many different signals that go back and forth to this T cell. And what the goal really has been in tolerance is to eliminate those that are self-reactive. And here we have mistaken identity in autoimmune disease. So that's the escape of a self-reactive aquaporin 4 reactive T cell or a MOG reactive T cell or any of the other ones that we can think of in different autoimmune diseases. So how does this occur? Why does it occur? I'm going to focus on two examples here. One is related to infection, and that's molecular mimicry. And then I'm going to speak to genetics as well. All of these are potential mechanisms, but we don't understand why someone develops NMO completely. We have strong evidence of possibly in mimicry, but stronger evidence on genetics. And so we do know that aquaporin 4 reactive T cells do exist in NMO patients. It's been over 10 years since it was originally identified that you do have in patients that there are T cells that recognize aquaporin 4, and they exhibit a Th17, a pro-inflammatory T cell bias. And some of those in this one publication here recognize one of the proteins of a bug that's found in the gut, Clostridium perfringens. And this is a later paper that has also shown the same as well. So aquaporin 4 has one area that we had found many years ago that is, in terms of molecular mimicry, is associated or is very homologous, is remarkably homologous to a region in Clostridium perfringens in this ABC transporter permease protein. And that's 9 of 10 residues. You can see all in the bold, but just the one residue here where there's a difference. And it was shown in this publication that T cells that recognized aquaporin 4 also recognize Clostridium perfringens. But that can't be the answer in NMO alone, because 95, 94% of individuals have Clostridium in the gut. And so that's only one factor. It may be important. There might be other bugs. And in that regard, when it was studied in patients in NMO, when we studied the microbiome in the gut of patients with NMO, we found indeed there was an overabundance of Clostridium perfringens. But it may not just be Clostridium perfringens, it may be other bugs, as this study here found that it was a different Clostridium here, Bolte, that was associated with NMO in a different population here in India. So there are different possibilities, and this is the example that highlights and underscores the importance of molecular mimicry. Now, genetics. Genetics are important, we know, in several different autoimmune diseases. We speak of diabetes, its association with DR3 and DR4, and with multiple sclerosis to DR2, meaning DRB1501, and which is DR2. It's interesting here that in NMO, there is an association with HLA, but the association is not just to the HLA. In this case, it's to DRB10301, which is known as DR17 or DR3, but also another gene that's located in that locus. And that's the complement factor here called C4a. And it's interesting because complement is so important in NMO. So we know the association to this one, but they're in linkage. They are closely associated, and distance-wise, it's very short in terms of genetic terms. It may be an association of DRB1, 0301 here, or to C4a, or both. So we don't know. Why are T cells important? I've spoken to the role of T cells in B cell maturation. What is the evidence in terms of an NMO? I spoke to the identification of aquaporin 4 reactive T cells in NMO, but we know that the antibodies are IgG1, and that's a T cell dependent subclass. So you have to have the T cells for that differentiation of those cells. Aquaporin 4 antibodies, if we transfer them in animals, do not cause disease alone, but only in the context or association with inflammation, sometimes T cell mediated inflammation, which we believe may drive the process. We also know that the pro-inflammatory Th1 and a particular Th17 cytokines have been identified. And within the lesions, T cells are sometimes found there, but their role may be predominantly outside the CNS, where they facilitate and promote the development of the antibodies, because in NMO, the lesions are characterized by a different cellular infiltrate, which are neutrophils and eosinophils. And as I pointed out, the association is this gene here in particular, also here, and in one other population, the DP1 star 0501. So these are the different genes that are associated with NMO. I'm going to switch gears, and we're going to speak to the therapy of NMO. And there are a couple things that we need to speak to first before we get there. We did not recognize NMO in itself. We thought of it as many years ago as an MS-related disease. It's not. It's distinct. You know that. But what we do know is that MS therapies are often contraindicated in NMO. Number one, interferons, in this case, type 1 interferon, which is the first therapy approved for treatment of MS, are contraindicated in NMO because they may make NMO worse. Secondly, natalizumab, which was approved in 2004, that is a very potent therapy that blocks migration of lymphocytes and monocytes into the central nervous system. And in that case, the disease is also made worse. That is, NMO is made worse if you misdiagnose a patient with MS and they have NMO and you give them natalizumab. So it's very important to know that. And similarly, fingolimod, the S1P modulators, all of them are also a concern where they may make disease worse. They make NMO worse. So what do we have for therapies? Before we had approved therapies, we had off-label treatment shown here at the bottom. We use steroids, we use plasmapheresis because of the antibodies. We use our steroid-sparing agents, Imuran, which is azathioprine, Cellcept, also known as mycophenolate, and we would also use rituximab. Now we have 4 approved therapies. We have eculizumab, which was the first one that was approved. The second one that was approved was inebilizumab here and satralizumab almost around the same time a year later. And then this past year, we had the approval of a second generation eculizumab or C5 convertase inhibitor like eculizumab, but called ravulizumab. It's an antibody that works as well, if not better, than eculizumab. Instead of being given every 2 weeks, it can be given every 8 weeks, and that's been an advantage. And I'm going to take you through the 3 different classes of therapies, just the clinical data supporting that. So first of all, with complement and the pathway, it's a very confusing slide here, but we can narrow that down to one region here. The classical pathway is what we're interested in. The antibodies to aquaporin 4 will activate the classical pathway, the classical complement pathway. That leads to a number of different complement factors. This one here is the C5 convertase, which is the target for eculizumab. And eculizumab and ravulizumab, I should say both, block that step. The terminal stage of all of this, the final common pathway, is the membrane attack complex. We often say MAC. And that requires from C5b to C9. And if you block that with C5, then you block the MAC, and patients respond to that therapy as shown here. This is the phase 3 trial that was performed long ago now, or not that long ago, 6 years ago. But in 2019, it was shown here that patients that were placed on eculizumab did incredibly well. This is a Kaplan-Meier curve. The endpoint here on their trial was a single attack, an adjudicated response, and most of the patients here remain free of attack. The patients on placebo, you can see, drop down. This was remarkably effective, and it's a remarkably effective drug. And that led to its approval in NMO. Now we have another therapy. We speak to B-cell depletion and the importance of B cells. And B cells, there are B cells that start in the bone marrow where they start their education. They then graduate and go into secondary lymphoid organs and into the circulation. What we know is that they have different markers here, CD19, CD20, MS. People are familiar with CD20. CD19 is interesting because wherever you have expression of 20, you have 19. But 19 starts earlier in differentiation and it extends further in differentiation. And earlier I showed a slide about plasmablasts and their dependence on IL-6. I'll come to that one in a minute. But the plasmablast is shown here is the primary cell making the antibodies. The plasma cells do too, but the cells that make the most are in the plasmablast stage. And CD19 eliminates not only the mature and memory B cells, but also the plasmablasts and gets into the plasma cell stage. And the data for this treatment, the anti-CD19, which is here called inebilizumab, was very effective. I'll show that in a minute, but it eliminates B cells down to a level of 0. Similar to what we see when we give CD20, we look at B cells, it is easily as effective, maybe even more in eliminating B cells. When we look at the data, this medication was tested not only in AQP4 positive, but also in a few patients that were AQP4 negative in this trial. Not quite 250 patients, but 17 of those were AQP4 negative. What you see here in the overall population, it's clearly effective. There's patients don't have an attack, and here with the placebo, some of them do. And you can see that there's the hazard ratio is shown here. And then if we look over here and we look only at the positive population, the drug appears to be even a little bit more effective. It might be effective in the seronegative, but we don't know, the hazard ratio being a little bit less. So in this case, we have tested both positive and negative. Now, let's go to IL-6. This here is the important point that we have. IL-6 is a growth factor for B cells, and it's found and increased in NMO, the expression and secretion of IL-6. We find that in the CSF, and it enhances the survival of plasmablasts. So this makes it a perfect candidate for treatment to block that step. And IL-6 is also important, not just in B cell differentiation, but also in T cells, and in particular Th17. So if you can block this step with IL-6, anti-IL-6, you can block possibly the B cell response and the T cell response. And this trial was also conducted in patients that were positive and negative for aquaporin 4 antibodies. And what you see here is that you have satralizumab, which is this case, the antibody for IL-6 versus placebo. You see a clear benefit here on the whole population. If you look at the patients that are positive, seropositive, you find that they have a lower risk of having an attack than those that are seronegative, where you can't convince yourself there's an effect. So in this case, the anti-IL-6 is very effective in patients that have seropositive NMO, AQP4 seropositive NMO, but not necessarily in patients that are negative. So we have eculizumab, which was only tested in the seropositive patients and approved only in seropositive. Ravulizumab was tested in seropositive patients in a smaller population. It's a unique trial where they used a historic placebo control from the first trial with eculizumab. And I had a smaller number of patients, and it led to the approval of ravulizumab, which again can be given less frequently than eculizumab. So it's a little more user-friendly. Inebilizumab itself is approved for aquaporin 4 positive NMO, may be effective in the seronegative. We don't know. We don't have enough information on that. And the last one was clearly also tested in, was tested in both positive and negative patients, but was clearly effective in positive and not effective in the seronegative patients. So all 4 drugs that we have are only approved for AQP4 seropositive NMO, not for the negatives. So that is an area of investigation now. So we come back to our slide here on tolerance. I mentioned the tolerance here, central tolerance at the beginning of the thymus, and peripheral tolerance here. We focused on T cells. We also have tolerance B cells as well, which I didn't describe their mechanisms, but some of them overlap. Now, what do we do from here? What about new therapies? Where are we going? We have different medications, the 3 that I've described. They're not specific, they're selective. One is selective for the complement system, the other one for B cells, the last one for a cytokine, IL-6. Ideally, we would have more targeted therapy because each one of the therapies that's approved has something that we would be concerned about that might relate to the immune suppression. If we can be more targeted with our therapy and eliminate only cells that recognize aquaporin 4, we may do better. And there's a great amount of energy being devoted to testing those therapies. One is dendritic cell vaccine. Another one is tolerizing with nanoparticles that express bits and pieces of the aquaporin 4. And the one here is a CAR T therapy, which you're familiar with, I believe, in oncology, but is also being tested in autoimmune diseases, including NMO. So what is a CAR T therapy? It's basically you can take a cell, your own cell, you can then add in, modify it in the lab, and express a certain receptor to the antigen. So you can make a T cell almost into a B cell, so it can recognize the antigen at the end. If you use the same T cells from the patient, you can return those T cells back to the patient, and those T cells recognize the autoantigen. And what they can do is they can go ahead and they can eliminate those T cells that are autoreactive or the B cells that are autoreactive. And a good example of that is with this system here, is that in the B cell system, we have cytokines that bind to BCMA. It's a B cell maturation antigen, and that's shown here. And these are cytokines that lead to the differentiation of B cells that can be pathogenic. And what's nice here about BCMA is it's expressed on mature B cells as they differentiate and become plasma cells. And so this has been a target for the first NMO NMO CAR T. And in this case, there was a very nice publication just 2 years ago showing that in 11 patients that were tested with an anti-BCMA CAR T therapy in patients that had been refractory to therapy, that they had given them aquaporin 4, an aquaporin 4 seropositive patients, that the BCMA therapy appeared to be effective. In fact, it's an open label study. We don't have a placebo control or another drug to compare it to, but it was remarkable in what they had seen in their follow-up with these patients over a period of 6 months to a year, about a year. And now this is in a phase 3 trial. It's jumped to a larger trial at this point. And that is going to be a controlled study and a phase 2, phase 3 study. So when we come back to it again, we have B cells shown here. We have T cells. And if we want to develop therapies that are more selective than what we have to understand the pathogenesis here on the B cell. Here we have those that speak to T cells, as I've described before. The B cell matures here and expresses not only CD20, it is expressing CD19. As I pointed out, the CD19 positive B cells, plasmablasts, they secrete antibodies. So CD19 has an advantage, we believe, and it's been shown in NMO and led to approval of this medication here, can block this step. And the T cells, we would like to develop therapies that might target just the Th17 cells, those that produce the IL-17. And that may occur with the satralizumab, as I pointed out, or we may have more selective therapies as well. For example, antibodies that are there. So the goal here is to prevent those cells from entering into the CNS and causing damage. So what I'm going to do here is just summarize what we have on our information from currently. On aquaporin 4 seronegative NMOSD, again, it's a relapsing disease. It's not progressive. The target is the astrocyte as the one that the cell that produces or expresses the antigen on the in the optic nerves and spinal cord. Aquaporin 4 itself is a water channel. Aquaporin 4 here, NMOIgG, is targeting the aquaporin 4. The T cells are polarized towards Th17. So we know that they're pro-inflammatory. Th1 is also pro-inflammatory, but in NMO, we see more of a bias towards the Th17. The inflammatory signature is distinct, and that is that we see an accumulation of neutrophils and eosinophils in the central nervous system. Seronegative NMO, which accounts for about 30% of patients that have NMO, is relapsing. It may be monophasic. The target here is we don't know. Again, it's optic nerves and spinal cord. Maybe other regions of the central nervous system can be targeted as well. But it's very similar in terms of its clinical phenotype. But we know less about that, not just the target of the antigen or antibody, but we don't know enough at this point about the T cells. In general, we would think that there may be more lymphocytes in the lesions in patients with the seronegative NMO. MOGAD, which is in the differential, is distinct. In that sense, it has a different target antigen, the MOG, myelin oligodendrocyte glycoprotein. It's monophasic, or it's relapsing. The antibody here to MOG is produced on the outside like it is in NMO. There's some evidence that it may be produced in the central nervous system. We don't know if the polarization is the same as in NMO at this point. The lymphocytes are the predominant cell type. In general, when we see lesions with MOGAD, the cell that's there most commonly is a CD4 positive T cell and a CD19 B cell, not neutrophils, not eosinophils. And this is all distinct from MS, which is both a relapsing disease and progressive. In the secondary phase, we used to call that secondary progressive MS. Now we just call it progressive MS. The target is a myelin antigen. It could be myelin basic protein, proteolipoprotein. It could be other CNP, other different proteins on the myelin. We initially thought MOG was one of those. It had been a candidate, but now that defines a separate disease. You don't have oligoclonal bands in some of these other conditions, but you do have oligoclonal bands predominantly in MS. Doesn't mean you don't get them in NMO. I shouldn't say you don't. You get them less frequently, and the same with MOGAD. In MS, we think of a Th1 differentiation and Th1 polarization, and the hallmark cytokine there is interferon gamma. Again, like in MOGAD, but a little bit different. You have a predominance of monocytes and lymphocytes in those particular lesions. So these are 4 different conditions, and we've really summarized what the different cell types that are involved. Our goal is really to develop more selective therapies with the knowledge that we have. So in summary, T cells, B cells, and antibodies are central in importance in NMOSD pathogenesis. They cooperate in causing damage. The current therapies were advanced through understanding the pathogenesis of NMOSD. We would like to develop more targeted therapy, and those targeted therapies are in various phases right now in testing in clinical trials. As I mentioned, just one of them, the BCMA CAR T therapy. And then further advances that we have in understanding may help us identify novel targets for seropositive and hopefully for seronegative NMOSD. And possibly it would be nice, especially if we could take what we know about tolerance and restore the immune tolerance that we so much have known in an individual that doesn't have NMO. Thank you.
Scott, thank you so much for a beautiful presentation. It is always great to hear you speak so clearly about a lot of complex interactions in the immunology of NMO and related disorders. So thank you so much. We've got a couple of questions. If we could sort of further explore these with you. The first question, Scott, is really about how these diseases might or might not coexist. So the question, do anti-aquaporin 4 positive and anti-MOG positive autoantibodies ever coexist in some patients, or are NMO and MOGAD distinct disease entities?
That's a great question. I would underscore, do they ever? I don't want to say they don't ever, but in general, these are two distinct disorders and they don't overlap. They can overlap, but only at a limited extent. So when a patient has antibodies to aquaporin 4, we rely on that in diagnosis for those that are seropositive. MOG is a little bit different, but they don't, in general, the patients that have MOG antibodies don't have AQP4 antibodies, and those that have AQP4 antibodies do not have MOG antibodies. There are a small fraction, maybe a small percentage at all, 1%, where you may, or 1 or 2%, detect MOG antibodies in patients with NMO. We also will detect MOG antibodies in other conditions such as stroke. And occasionally you'll find it with MS patients or other conditions that are unrelated to MOGAD. And we're having some challenges with the antibody with MOGAD because the titers don't always correlate with the disease as nicely as they do with NMO. We rely on the association of the antibody with AQP4 antibodies with NMO. A low titer of MOG antibodies can be found with other conditions, and the patients don't have MOGAD.
Scott, let's stay on this question for a moment. There's been some recent evidence that, for example, anti-aquaporin 4 antibody can emerge well before the symptoms of NMO are noticed. Can you speak to that a little bit, and what does that mean in terms of the immunology of NMO, for example?
So that's a great question. It really speaks to the point that there's more than one process. There's many different pieces in the pathogenesis of NMO. Just as I mentioned before with Clostridium perfringens could be one, but everybody's exposed to AQP4. Yeah, I mean to Clostridium perfringens, excuse me. My point is that you can have different steps and you don't necessarily have the disease. So having the antibody alone may not give you NMO, even though the patients that have NMO do have the antibody. Because remember, in the animal studies that have been done where we do understand pathogenesis, you don't get the disease without some cellular inflammation, something in the central nervous system. So if you have a pro-inflammatory T cell or a pro-inflammatory B cell for that matter, or in others, they can help, or what they do is they distort or disturb the blood-brain barrier and they permit the antibody to enter the CNS. So in general, the antibodies would only enter the CNS in the context of having some inflammatory response. So you could have a high titer in the periphery, but if you don't have that cellular insult, the antibodies may not enter the CNS.
And Scott, one last question on this topic has to do with the overlap of distinct autoimmune diseases. For example, in some patients who have anti-aquaporin 4 positive NMO, before they had NMO, they had antibodies that were related to diseases like myasthenia gravis or lupus. Does that tell us something more broadly about loss of tolerance to multiple autoantigens in these conditions?
It may tell us that there's a disturbance in the tolerance to several different autoantigens, and it may also tell us that in some of these conditions that there may be some overlap in the particular antigens. As I pointed out on the one slide, the aquaporins are expressed in different tissues, aquaporin 4 is in different tissues. We know that for some of these disorders, they have similar genetics with NMO. The number one allele in NMO being HLA DRP1 0301, which is more easily just said DR17. But that is the allele with Sjogren's. And it's one of those that is found, not the highest, but also found in lupus. So we do wonder if there's some common features between these conditions, especially when the NMO patients have other coexistent autoimmune diseases.
That's very helpful, Scott. Thank you so much. A second question has to do with the idea that you mentioned that certain medications that are approved for other diseases that are similar to NMO might actually be bad in NMO. And one of the examples you gave was beta interferon. So can you talk a little bit about the mechanistic basis for why beta interferon might exacerbate anti-aquaporin 4 NMO while it can be helpful in MS?
That's a great question. We don't have the answer entirely for that, but we do have strong evidence in NMO where it may interfere. But you have to ask the first question. The type 1 interferons are the first approved therapies in MS back in the 1990s. And the interferons then were shown to have a multiplicity of effects. Okay, they're interferons interfere with viral infection, a type 1 interferon. But what they do is that they inhibit certain enzymes that permit entry of cells into the central nervous system. So they act at the blood-brain barrier. So they inhibit the matrix metalloproteases. They are also immunomodulatory, and it was shown at the time or shortly after they were approved, because they were effective in reducing inflammatory lesions in MS, that they induce the interferons, type 1 interferons, induce the anti-inflammatory cytokine called IL-10. And that was another feature. But that stands different with NMO because in NMO, excuse me, there is a interferon signature. And so that what we've seen in studies that have been done on patients with NMO in investigatory type studies that are basic and in vitro and may relate in vivo, is that the interferon itself is promoting B cells to produce IL-6. And IL-6 is the hallmark pro-inflammatory cytokine. And they're acting, in this case, the interferon may be acting on the B cell to produce, where it would be helpful in MS, it would be problematic or potentially contraindicated, or it is contraindicated because of this effect where it may promote pro-inflammatory T cells and B cells, in particular B cells, and that way promote antibody secretion.
And Scott, is there also another pathway that might be involved? I'm thinking about the idea that type 1 interferons like beta interferon suppress type 2 interferons like gamma interferon. And because gamma interferon counterregulates Th17 polarization, you might actually be de-repressing Th17 polarization by adding beta interferon. Is that still the way we should be thinking about this?
I think that's another way to think of it. It's a good way to think of it in terms of what we have is that the type 1 interferons and the type 2 interferons, they have different receptors, and the type 1 interferon receptor leads to activation of different molecules that downregulate the interferon gamma pathway. The interferon gamma pathway, as you point out, which is the primary pathway for inducing MHC class II and activation of pro-inflammatory gamma secreting Th1 cells. So that is itself, the interferon beta itself is turning off the type 2 interferon, the interferon gamma. And that's exactly right. And there is a difference, and they do compete in some ways, that there's a yin yang between Th1 and Th17. So if you turn off Th1, you may promote Th17. It's interesting because we've seen that in another therapy, which is with natalizumab, which blocks entry into the central nervous system, we've seen a difference in that it seems to block Th1. It may permit Th17. We may see differences in blocking the penetration of cells for that particular drug, where that one is also contraindicated.
Really interesting stuff, Scott. Thank you so much for walking us through that. A third question has to do with the sort of effects of triggers versus genetics in different kinds of demyelinating autoimmune diseases. And from what you really emphasized, it sounds like it's a combination lock. In other words, there are multiple players that might be involved. Could you just sort of walk us through the difference between a trigger and a genetic or inherited type of determinant in these diseases?
Okay, that's a really nice question. And those are two different aspects of susceptibility to disease. I mean, the genetics being the susceptibility, they are different in different autoimmune diseases. So we find linkage on different diseases. For example, type 1 diabetes is highly associated with DR4 and then DR3. We have certain diseases involving the spine, the spondyloarthropathies, the ankylosing spondylitis, which is associated with B27. And myasthenia may be a different one, and the same with other diseases, like with NMO, I mentioned with the DR3 or DR17, the DRB10301. So the genetics may be distinct. The triggers may also be distinct, but the common feature is that there may be bugs that induce the mimicry, and they may be different because the antigens are different. But the common part of that is the triggers, each one could be triggered by a vaccine of infection. Well, I would say infection more likely, but they may be different infections because there are different autoantigens in each of these conditions. So the exposure of Coxsackie might be associated with, with diabetes. It could be another virus. For example, we have now so much excitement on the Epstein-Barr virus and associated with MS. And that may be in part due to molecular mimicry, but it's a different virus and it has a different HLA association.
I was thinking the same thing, that, if you look into the literature and search, infection relationships with NMO, for example, you'll find a bunch of different organisms, some viral, some bacterial, for instance, that have been associated in some cases with NMO. But the fact that there are many different types of microbes that may be associated with these diseases suggests that, as you said, that the triggers are processed by the genes, and the genes then display pieces of these microbes to T cells and B cells, and that kind of gets the ball rolling. Is that how we should be thinking about this?
Yes, I think that's really a good analogy. And just to underscore the importance that there are multiple steps, multiple safety nets in preventing autoimmunity. And it just highlights that each one of these steps may be important and contribute, but it doesn't happen. You don't get the disease unless you pass one, checkpoint to another checkpoint to another.
Very good, Scott. Thanks for addressing those questions. One last question I think that a lot of people are very excited about has to do with the potential for restoring immune tolerance as a therapeutic way to treat or perhaps even cure these autoimmune diseases. And so the question really relates to the idea, do any of the approved therapies restore immune tolerance, or is that approach to restore immune tolerance a different strategy than the approved therapies today?
So both are true. You would like to work upstream. It would be helpful. We think of disease treatment, we think of prevention, and prevention means working upstream. We think of certain therapies that we have now in NMO, we have 3 classes of medications, and that's great that they're not 3 medications in the same category, like 3 different interferons, but they have different mechanisms. We know the final common pathway is complement activation. To me, that's where damage from a scientific standpoint, and that blocks that step. But if we stop that medication, the condition then recurs. We are concerned because each one of these medications, by blocking a step in immunity and protection, may confer susceptibility to another infection. There can be immunosuppressive. The B cell therapy knocks out B cells throughout the stage, the CD19, as I talked about, from pro B cells all the way through to the plasmablast. So that's working upstream and downstream, but not enough. It's really a pan-specific antibody, or it's pan-specific for B cells, and that's not desirable. We would like to have therapies where we could target upstream only those cells that are targeting the autoantigen. We're getting at it by understanding more about the pathogenesis. So T cells and B cells are involved. What are the cytokines? We've found that Th17 is important. IL-6 is important for Th17 differentiation, and IL-6 is important for B cell maturation. But that's for all B cells and really for all Th17 cells. Ideally, we would have a means of going after the cell type that is involved. So for example, if you had the nanoparticles or another means, a dendritic cell that expressed the right antigen, in this case, aquaporin 4, maybe not a peptide, but the whole molecule, then you might be able to tolerize. And that itself, caught early enough, would prevent disease from getting worse or an NMO relapse. I think by understanding disease more so over time and understanding the genetics and what these triggers may be, we may get to prevention. And I think that would always be our best.
Scott, there has been incredible advance in the field of NMO and related diseases in the last 15 plus years. You've been a big part of that. We really appreciate all that you've done to help the field move forward from science into medicine and hopefully from treatments toward cures. So thank you very much for your great work. Thanks for being a presenter in the NMOSD Grand Rounds series. We really appreciate your efforts.
Great. And thank you for the opportunity to speak at the NMOSD Grand Rounds.
Well, we had a great presentation today from Dr. Zamvil. Please note that this presentation and all of the presentations in the NMOSD Grand Rounds series are eligible for continuing medical education credit. For this credit, please visit the GJCF Education Center using the QR code shown here. Select the session that you would like to review and register for that session. View the session to fulfill CME credit, and then receive your certification for CME online. We'd like to remind you that the series of NMOSD Grand Rounds is going to continue. The next session is toward harmonized relapse and severity adjudication, and that will be presented by Dr. Brian Weinschenker. Of course, all of these sessions can be accessed through the Guthy-Jackson Charitable Foundation Education Center. You can see the QR code here, and included in this center are the NMOSD Grand Rounds, a number of educational events, and other presentations and media. We greatly appreciate Alexion and the AstraZeneca Rare Disease Division for sponsoring the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds. We really appreciate their support of education. And again, thank you all for attending this session of NMOSD Grand Rounds.